I'm often asked, who do you offer PTNS to? Well, for myself, anyone that has overactive bladder, that's failed medication, so it's refractory OAB, I call it ROBE. So you have ROBE. With some exceptions, I offer them, which one would you like? Botulinum toxin, sacral nerve stimulation, or PTNS? Because for myself, I don't know what you may like or I may like, and certainly I'm not going to just offer the relatively more invasive ones without the least invasive one, PTNS. So it's really a choice versus the other two treatments if you are a refractory patient. Probably the largest group, but they're still offered in some cases all three, depending on how frail they are, is the elderly, the frail, a lot of medical comorbidities. You walk in the room and you just know my algorithm is going to be, I'm going to use behavioral and medical therapy, and if this fails, they're going to be offered PTNS, because they're going to say, no thank you dear, or I'm not even bringing up botulinum toxin and sacral nerve stimulation to that patient population. And that is a lot of patients. There's a lot of patients in their 80s that love when you help them, and it's actually very gratifying when you do, and those folks need to be treated. There's a lot of other groups that my urology friends and urogynecology colleagues may not think about as much, but there's a lot of patients with overactive bladder symptoms that have underlying neurologic issues, multiple sclerosis, Parkinson's, and with their medical issue, this can be a really good treatment for them. I think a very important group of patients or populations is patients with milder symptoms. They're bothered by them, their frequency and their urgency. They may rarely leak, they're getting up at night, but they're bothered and they fail the medications. But they just don't want something that they perceive as invasive as, let's say, a TURP of the prostate or sacral nerve stimulation or botulinum toxin. They'll just say, I'll just live with it. But if you say, oh, I'll come and have my ankle stimulated for 12 weeks, I'm retired, and if that helps, great. A very important cohort as well, this is very clinically relevant, is overactive bladder with nighttime frequency. If you do a diary on them, yes, a lot of them have a diuresis, but they have a small functional bladder capacity. At 200 mils, their bladder's saying, get up, get up, get up. And percutaneous tibial nerve stimulation, the data clearly says it works. In our practice, you can ask Jamie. I'll go in the room and say, oh, I hear Jamie tells me your urgent continence is a lot better. You're at 2 pads instead of 5. Oh, Dr. MacDiarmid, my nighttime frequency. So nighttime frequency, this is a great treatment in your algorithm in treating these patients. It's imperfectly good therapy, but it's the closest thing we have to neuromodulation for the masses.